Hello, good morning.
Good morning, sir.
Achha. Video is clear? Picture?
Yes, sir. Video is clear, sir.
Okay. What about sound? Audio? Sound?
Audio is also clear, sir.
Clear. Okay. Then let us start now. Hello.
Yes, sir.
Okay. Today I shall start a new chapter, new topic. Urolithiasis means kidney stones. Okay. So to start with this new chapter, we shall begin with epidemiology. Here, approximately 10% of Caucasian men, 10% of Caucasian men will develop this kidney stone by the age of 70 years, right? 10% of Caucasian men will develop kidney stone by the age of 70 years. And remember, once they develop the renal stone, particularly calcium oxalate stone, then within next 1 year time, 10% of this patient will have the same stone. That means within 1 year of a calcium oxalate stone formation, 10% of this man, that means 10% of these patient will have another calcium stone formation. Okay, recurrence will be there. And 50% of these patients, those who already developed stone, 50% of these patients will have another stone within next 10 years, right? So recurrence is very, very common. Within 1 year, 10% population will, 10% patient will have another stone, and within next 10 years, 50% of this patient will have the recurrence. That means we will have another renal stone. This peak incidence of the renal stones occurs between the 20 and 50 years, and male are affected 3 times more than the female. So what are the factors? That means etiology. What are the causes of urinary stone formation? How you will classify them? How will you classify the causes of urinary tract stones? Number 1 is idiopathic calcium urolithiasis. Second is hypercalcemia. Hypercalcemia, that means serum calcium level is higher than the normal. Then another cause is renal tubular syndrome. Fourth is uric acid lithiasis. Fifth is enzyme disorders. There are some enzyme disorders leading to stone formation. There are some secondary causes of urolithiasis and other factors. So urolithiasis may be because of supersaturation of the urine. And this supersaturation of urine occurs because of excessive amount of calcium or oxalate in the urine, or this supersaturation may be because of the reduced volume of urine formation. Okay, either because of the reduced urine volume or excessive amount of calcium or oxalate, there will be supersaturation and ultimately will lead to urolithiasis. And there are some other factors which will help or may lead to formation of renal stone. These factors are metabolic disorders. Some metabolic disorders like hyperparathyroidism, gout, and genetic disorders and infection some infections will have urolithiasis. And there are some promoting factors like uric acid, high uric acid level, high calcium, and high oxalate and cysteine, all will promote to form the urolithiasis. So these are the three factors mainly playing to form the renal stone. But we are fortunate enough, there are some factors which inhibits, which will prevent the stone formation. These are the low level of magnesium citrates which will prevent the urolithiasis. That means formation of renal stone. So etiology, first most common cause of stone formation is idiopathic calcium urolithiasis. Idiopathic calcium urolithiasis. Here what we will get, there will be unexplained hypercalciuria. That means what? Hypercalciuria. That means excessive loss of or excretion of calcium in the urine. There will be excessive rise of calcium in urine, and this is, you cannot explain why there is excessive loss of calcium in the urine. This is known as hypercalciuria. When you will call it hypercalciuria, or at which level there will be stone formation? If this excretion is more than 7 millimole in man, excretion of calcium in urine is more than 7 millimole in case of male, and more than 6 millimole in woman, there is, you can label it hypercalciuria, and ultimately will form to calcium stone, renal stone. But remember, though there is hypercalciuria, but patient will have normal serum calcium. This is very important. Patient will pass excessive amount of calcium in urine, but there is normal serum calcium level, no rise in the serum calcium level. And this idiopathic calcium urolithiasis, we can classify it as renal or absorptive. That means this renal, what will happen? There will be excretion of calcium in the urine because of some renal pathology. We don't know what are the renal pathology, and it is seen more in children. Or there may be absorptive. That means there will be more absorption of calcium in the gut, and it is very common in adult population. Okay, and you remember, this idiopathic calcium urolithiasis is present in approximately 70% of patient, 70% of patient with urinary stone. That means if you get a patient, 100 patient of urinary stone, in 70% of them, in 70% of this 70% patient will have the main cause is idiopathic calcium urolithiasis. That means they will have hypercalciuria but normal serum calcium. Okay. Then second most important cause is hypercalcemic disorder. Hypercalcemic disorder, that means here this patient will have hypercalcemia. That means serum calcium level will be high. And because of this high serum calcium, some of this patient will develop urolithiasis. What are the conditions where we will get hypercalcemic disorders? Number one is primary hyperparathyroidism. That means primary hyperparathyroidism. In parathyroid adenoma or chip cell hyperplasia, what will happen? There will be overproduction of parathormone from the parathormone gland. Okay, and this overproduction of parathormone will increase the synthesis of 125 dihydrocholecalciferol. Okay, 125 dihydrocholecalciferol, and this will lead to increased intestinal calcium absorption. Okay, and ultimately will have renal tubular reabsorption and bone resorption, and ultimately what will happen? There will be stone formation, renal stone formation, and this condition is found in less than 5% of patients with radiopaque stone. Okay, another cause of hypercalcemia is the prolonged immobilization. That means the patient who are immobilized for a long duration, immobilized in the bedridden patient, they will have hypercalcemia, and this hypercalcemia will have again hypercalciuria also. Right here, hypercalcemia and hypercalciuria both you will see, but in the idiopathic calcium urolithiasis, only hypercalciuria you will get. But here you will get, along with this hypercalcemia, you will get hypercalciuria. Okay, and this is because of bone resorption. As the patient is immobilized for prolonged duration, there will be resorptions of calcium from the bone. Bone resorption will take place and patient will have hypercalcemia and hypercalciuria, right? Then is the milk alkali syndrome. What will happen? Here there will be ingestion of large quantities of calcium, vitamin D and alkali. And because of this ingestion of large quantity of calcium, vitamin and alkali will result into hypercalcemia, alkalosis and possible renal impairment. And this hypercalcemia, particularly this alkalosis, compromises the renal excretion of calcium and promoting hypercalcemic induced soft tissue calcification. This alkalosis, because of this ingestion of large quantity of calcium and vitamin D and alkali, will lead to renal impairment, okay, and compromises renal excretion of calcium and promoting hypercalcemic induced soft tissue calcification. That means soft tissue calcification of the kidney. In the kidney there will be calcification, okay, and this is known as nephrocalcinosis. Soft tissue calcification of kidney is known as nephrocalcinosis, and there will be stone formation in the collecting system. It may be in the calyx, pelvis or ureter. This is nephrolithiasis. Okay, another cause of hypercalcemic disorder is sarcoidosis. In sarcoidosis, what will happen? There will be non-caseating granuloma formation, and from this non-caseating granuloma will produce 125 hydroxycholecalciferol, and as I have discussed earlier, this will lead to excessive ingestion or absorption of calcium and ultimately will help into the formation of renal stone. What are the other causes of your hypercalcemic disorders? Other causes is disseminated neoplastic diseases, disseminated neoplastic diseases, Cushing's disease and hyperthyroidism, all these disease will lead to your hypercalcemic disorders. That means there will be more calcium level in the blood, and ultimately patient will have renal stone formation. Another cause of renal stone formation, another etiology is renal tubular syndrome. In renal tubular syndrome, we'll get in different conditions. One is renal tubular acidosis. There are different types of renal tubular acidosis. Out of all, type 1, out of these 3 different types of renal tubular acidosis, this type 1 is associated with stone formation, renal stone formation. And stone formation here is because of hypercalciuria. Hypercalciuria, excessive excretion of calcium in the urine, and low urinary citrate excretion. Citrate is you see, citrate is a preventing agent. That means it prevents stone formation. But when there will be low citrate excretion in the urine, this and hypercalciuria, excessive excretion of calcium, this will favor will promote the stone formation. Okay, so here what we will get in renal tubular acidosis: pure calcium phosphate and nephrolithiasis. Okay, pure calcium phosphate stone and nephrolithiasis we will get in renal tubular syndrome, acidosis. Then another condition is cysteine urea. Then cysteine urea results from inherited defect. Why cysteine urea you will get? This occurs because in inherited defect of amino acid transport. Here, this inherited defect of amino acid transport you will get in the renal tubules and GI tract, GI tract. What is coming? Okay. This cysteine urea results from inherited defect of amino acid transport in the renal tubules and GI tract, and ultimately the cysteine stones will form, and these cysteine stones are often, these cysteine stones are multiple, and they are very hard and radiopaque, right? Then another condition is uric acid lithiasis. You have heard definitely this uric acid lithiasis, and it is account for approximately 1 to 10% of urinary stones. Uric acid lithiasis, you will get around 5 to 10% of patient. Okay, patient with uric acid stones either excrete excessive amount of uric acid or have excessive acid urine. Okay, excessively acid urine, right? Here you will get, they will excrete excessive amount of uric acid, or they will have excessively acidic urine. Uric acid stones can also occur in patient with normal serum uric acid level. That means in normal, if the patient is having, some patient will have normal serum uric acid level and will develop this uric acid lithiasis, and this is because of, this is idiopathic. Low urine volume may contribute to uric acid stone disease. Already I have mentioned, low urine volume will precipitate, will help to concentrate this urine, and there will be more precipitation and ultimately stone formation. Uric acid stones, these uric acid stones are very hard, smooth and often multifaceted, and these are radiolucent. Uric acid stone are radiolucent. There are some enzyme disorders will lead to stone formation. These are deficiency of enzyme like alanine glyoxylate aminotransferase type 1 and D-glycerate dehydrogenase type 2 lead to an increased production of endogenous oxalate. This is very important. This deficiency of these two enzymes will lead to increased production of endogenous oxalate, which results in calcification of the soft tissue of kidney, nephrocalcinosis and nephrolithiasis. Then Cysteine Urea, it is rare inherited deficiency of xanthine oxidase. This is an enzyme disorder, and ultimately stone formation can be, and this xanthine oxidase deficiency may be precipitated because of this allopurinol. If this patient having this xanthine oxidase deficiency, if they get the allopurinol, and this will lead to stone formation, right? Then there are some secondary causes of urolithiasis. It may be secondary hyperoxaluria. That means hyperoxaluria means there will be excessive excretion of oxalate in the urine. Okay, and this secondary hyperoxaluria, what will happen? When it will happen? When there is increased oxalate absorption. This increased oxalate absorption may take place after small bowel resection. That means after resection of large sufficient length of small intestine, and there will be more oxalate absorption. And in some inflammatory bowel disease, in chronic pancreatitis, and in duodenal bypass, what will happen in all these conditions? That means in small bowel resection, of course, it should be a sufficient length of resection. Small resection will not lead to any problem. In inflammatory bowel disease, chronic pancreatitis, duodenal bypass, that means reducing this absorptive surface area of small intestine will lead to increased oxalate absorption, and this increased oxalate absorption will lead to hyperoxaluria, and there will be stone formation in the kidney. Some dietary excess of rhubarb, spinach, tea, coca, chocolate, and pepper, commonly they increase the urinary oxalate. Okay, infection, following infection of this Proteus, Pseudomonas, Staphylococcus, and these organisms will break down this urea to produce ammonia and carbon dioxide. Okay, and ultimately, because of this production of ammonia and carbon dioxide, this urine will become alkaline, which promote formation of struvite calculi. Struvite calculi means is the calculi which is composed of magnesium, ammonium phosphate. Okay, and this struvite calculi can grow silently and may ultimately it may form a staghorn calculus. There is some obstruction and stasis may be the cause, which this obstruction and stasis in the urinary flow delayed the crystal washout. If there is obstruction or obstruction in the excretory system, or if there is stasis of urine in the excretory channel, there will be delayed washout of the crystal, and this delayed washout of crystal will lead to aggregation and stone formation. Medullary sponge kidney, this is you'll get in 20% of patients with calcium stone may have this medullary sponge kidney. Then urinary diversion also may lead to stone formation, and here stone developed due to combination of infection, acidosis, and sometimes stasis. Urinary diversion means in some, suppose patient is having CA bladder or there is malignancy in the pelvis, and you have to treat that condition, you remove the bladder and all these things, extensive dissection done, and you have transplanted the ureter into the small intestine. So you have diverted the urine in the other excretory part like small intestine. Okay, so this is urinary diversion. And this urinary diversion, following this diversion, what will happen? As you have implanted into the small intestine, so there will be every chance of infection and acidosis. Okay, and this infection and acidosis will lead to and along with some stasis will lead to stone formation. So the patient who are having urinary diversion, there is more chance. I have mentioned about the urinary diversion. Next is the drugs. There are some drugs which will precipitate or will help in the stone formation. Okay, and these common drugs are acetazolamide, which stimulate renal tubular acidosis, and acidosis ultimately will help in the stone formation. And allopurinol, already I have mentioned, may precipitate xanthan stone formation, and thiazide diuretics can result in uric acid stone formation. There are some other factors like geographical location, climate, and season. And renal stone disease is more common in hot climates. Ureteric stones become more prevalent during summer, and exposure to sunlight may also increase the endogenous vitamin D production and leading to hypercalciuria and ultimately stone formation. Water intake is very, very important in the stone formation, and low water intake, that means if you take less than 1200 ml of fluid per day, may predispose to stone formation. Okay, so every day a person should take at least 1.5 liters of water regularly. Otherwise, if it is less than 1200 ml, they are very much predisposed to stone formation. Then increasing water hardness, that means high calcium content, may reduce the risk of stone formation by decreasing urinary oxalate. This high calcium content of urine will reduce the excretion of oxalate in the urine and thus preventing the stone formation. This is very important. Previously, people used to say, don't take any food or anything which is containing high calcium. This was a totally wrong concept. Okay. Then what is the physiochemistry of stone formation? Already I have mentioned this urine must be supersaturated. Urine must be supersaturated for stones to form. Okay, and this supersaturation alone is not sufficient for stone formation or crystallization to occur, because there will be some presence of some urinary inhibitors. Already I have mentioned there are some urinary inhibitors. If the urinary inhibitors are sufficient, even in supersaturation of urine may not lead to stone formation. Nephrocalcin, remember nephrocalcin, uropontine, TAM horsefell protein, these are important inhibitors of crystal nucleation and growth and aggregation. That means these are inhibitors of stone formation. Nephrocalcin, uropontine and TAM horsefell protein, these are inhibitors of stone formation. Urinary calcium and oxalates are equal contributors. Calcium and oxalates are equal contributors to urinary saturation of calcium oxalate. Okay. Common calcium stones may originate from the subepithelial plaque, and non-crystalline component of stone is known as matrix. What is the composition and percentage distribution of renal stone? Most common renal stone is the calcium oxalate stone. Most common stone is the calcium oxalate stone. You'll get percentage of it 85%. 85% renal stones are calcium oxalate stone. Then uric acid stone 5 to 10%. Calcium phosphate plus calcium oxalate, you'll get in 10%. Pure calcium phosphate, very rare. Pure calcium phosphate stone is very rare. And struvite, already I have mentioned, the infection stone or staghorn stone, you will get in 2 to 20% of patients. And cysteine stone only in 1%. Here, oxalate stone types, oxalate calculus. This is oxalate, calcium oxalate. Okay. Here you see spiky, surface is spiky. And these oxalate stones are irregular and sharp projection you will get in the surface. Okay. And these stones are very hard and radiodense. And because of these spikes in the surface of the stone, it will irritate the tissue of the kidney, or there will be irritation where it is lying. Okay, so it will irritate the kidney tissue, and there will be bleeding. There will be bleeding from the surface of the kidney, and patient will have hematuria. Right. This is a very peculiarity of the oxalate calculus. Right. Then is the phosphate calculus. Phosphate calculus, it is calcium phosphate often with ammonium magnesium phosphate. That means infective. Calcium phosphate often with ammonium magnesium phosphate, which is known as struvite stone. And these struvite stones are smooth and dirty. Color is dirty white. In the oxalate stone, because of spiky, it is surface is rough, and because of the spike, there will be bleeding, and this hemoglobin or RBC will be deposited over the surface. So these stones will have dirty color. But in phosphate calculus or struvite calculus, the surface is smooth, and color is dirty white. And as surface is smooth, there will not be any bleeding, and color is dirty white. Remember it. And this grows in alkaline urine, especially, and as already I have mentioned, this is infective stone, and especially when the urea splitting organism, already I have mentioned, urea splitting organism leading to this alkaline urine and ultimately stone formation, this triple phosphate or stuvite stone. Okay, and the calculus may enlarge, and as I have mentioned already, this calculus, this stuvite calculus may enlarge silently, may enlarge to fill the most of the collecting system, that means pelvis, calyx, minor and major, and form a staghorn calculus, Even a large staghorn calculus may be asymptomatic for years until it presents with hematuria and urinary infection. Mostly it presents with urinary infection. I am going to show you the staghorn calculus. Here you see. And this staghorn, because of it will take the shape of the pelvic calyceal system. This portion is lying in the pelvis of the kidney, in the major pelvis, and these are the extension towards the calyces of the kidney. So it will take the shape of staghorn. This is staghorn stuvite stone, infective. Another type is uric acid or uric acid stone. These uric acid stones are very hard, smooth, and often multiple and multifaceted. Okay, and these pure uric acid stones are radiolucent. That means if you take the X-ray, you will not get any opacity in the film. It is radiolucent. So how will you diagnose it? This, if you go for CT scan, this CT will distinguish them from the other causes of filling defect. That means filling defect is that. Okay, and this filling defect may be because of tumors in the ureter. And most uric acid stones contain, but most of the uric acid stone contain some amount of calcium. And as they contain some amount of calcium, they are not completely radiolucent. There will be some, you will get a faint cast in the X-ray. Faint radiological shadow you will get in uric acid. But pure uric acid stone is radiolucent. But most of the uric acid stone will have some calcium component. Then cysteine calculus. This is very uncommon, and because of congenital error or metabolism leading to cysteine urea, and these cysteine stones are often multiple and may grow to form a cast or collecting system. Okay, and these cysteine stones are radiopaque, and this is very, very hard. The cysteine stones are very, very hard. Okay, and this radiodensity, if you, these stones, you have to know the density of the stone. Radiodensity you'll get on X-ray, and this radiodensity on X-ray mainly, this opacity mainly depends on the amount of calcium present within the stone. More calcium, it will be very clear. It will have a opacity, clear-cut opacity in the X-ray. So this radiodensity mainly depends upon the presence of calcium in the stone. More calcium, good opacity. Easily you can see in the X-ray. Okay, and depending upon the density, you can divide these stones as radiopaque stone, relatively radiolucent stone, and completely radiolucent. Radiopaque means they will create shadow in the. Radiolucent means no shadow. Okay, in common terms. And radiopaque stones, what are the radiopaque stones? Calcium phosphate stones are most radiodense. The stones which are containing calcium phosphate, they are more radiodense. Okay, calcium oxalate stones are slightly less, but they will create shadow. Okay, radiodense. Relatively radiolucent. Okay, These are the cysteine stones, and struvite stones are less radiodense than the calcium containing stone, but they will create opacity, but a bit less. But some stone are completely radiolucent. They will not have any shadow in the ordinary X-ray. These are the uric acid stone, triametrine, xanthine, indinavir stones. These are completely radiolucent stone. Then these are the different etiology and characteristic features of the stone, and which of the stone will be easily visible in the X-ray. And patient with renal stone, what will be the presentation, how they will come, with what problem they will come to the doctor. And patient suffering from urolithiasis, you can divide into two groups. Divide this patient into two groups. One group is symptomatic patient, another group is asymptomatic patient. Symptomatic patient, that means they will have some symptoms, they will come with some symptoms. Asymptomatic patient, they are not having specific symptoms of urolithiasis. They may come for some other problem. Okay. So in symptomatic patient, what you will get? What are the symptoms you will get? The symptoms are pain and hematuria. Regarding this nature of pain and hematuria, we have discussed in details in the earlier classes. Okay. And in asymptomatic groups, they will come to the clinic with some other problem, and you will find they are having urolithiasis. On urolithiasis, you will diagnose urolithiasis incidentally during the investigations of the other problem for which he is in the clinic. Okay. So this patient may be silent. Some patient with the urolithiasis may not have any symptoms, may not create any problem, and these are silent stones. And silent stones may damage the kidney. There may be some other problem. They may create some problem in the patients, but remain silent. So it's very dangerous. Silently, it will kill the patient. And some of these patients may present with renal failure. This may be the first symptoms. If it is, the silent stones are bilaterally present. That means bilateral renal calculi, staghorn or something. Struvite staghorn calculi are classically present with. Already I have mentioned this struvite staghorn calculi. These are because of infection, urea splitting enzyme organisms are leading to this staghorn calculi. And usually, so what will be the presentation of the patient? Will have recurrent urinary tract infection. Okay. This is the fixed pain of the renal calculi. Patient will have pain in the renal angle. Renal angle we have discussed in the earlier class. Okay. Patient will have pain, and this pain is dull aching pain. It is not renal colic, it is renal pain. Okay. And if it goes to the ureter, patient will have ureteric colic, and this ureteric colic, this pain will radiate downwards towards the iliac fossa and to the external genitalia, and the patient will have severe pain. In ureteric colic, patient will there will be tossing over the bed, and patient will have vomiting once or twice. Okay, so this will be the presentation. Some patient will have hematuria. So next is how to investigate and how to manage it. Okay. So let us finish it here today. In the next class, I shall discuss mainly about the investigation and treatment. That means management part I shall discuss in the next class. Okay? Right? Thank you all.